लोगों को लगता है कि हम मीठा खाएंगे तो डायबिटीज होगा, नहीं खाएंगे तो नहीं होगा. So complete misconception. We have almost close to 10 crore people with diabetes, and around 13 crore people who are borderline and who are very hungry to join that gang. And obesity drives diabetes, heart disease, kidney disease, blood pressure, cholesterol, everything. 200, 300, 400 years back, our genes were developed in such a way that whatever you eat gets stored in your body. Because of so many modernization, your activity goes down, you become more sedentary, you get more stressed in life. So everything adds on to this whole wrong gene. Now, technology has gone up and the investigations have gone up that we can actually have a kind of a kundali for the diabetes patient. You can actually look at what can happen for you in future. 2040, majority of the deaths which are occurring in India would come from non-communicable disorders, which puts diabetes, cardiovascular disease, cancers. They will be the drivers for that mortality. Now, food is fuel for us. You know, that's how our body runs. But the younger generation is looking at food to make sure that they look better.
But realistically, do you think maybe like a decade or two down, especially with some of the things that you're talking about in terms of technology, at any point of time, do you think there's a possibility of a cure coming in for diabetes? Hi, and welcome to another episode of Expert Talk with Bhavya Desai. Today, I'm talking to Dr. Rajiv Kovil, who's a very renowned diabetologist from Mumbai. He's also a very good friend of mine, and I've known him for many, many years. The reason why I feel this conversation is very important is because it focuses on diabetes, which is a rampant condition that a lot of the youngsters, a lot of people go through, and that also gets attached to a lot of things that you might have but you won't even know. For example, it can have effect on your normal health, on your organs, on your sexual drive, on your interpersonal relationships and general life. So this one's really good because I feel it was a very, very good and interesting conversation. So I hope you like it, and of course if you like this conversation, then please like, share and subscribe to our channel. Also look us up on Instagram as well, because we'll be getting you so many more episodes like this. And until next time, see you in the next one. Alright, so Dr. Rajiv Kovil, welcome to the podcast Expert Talk with Bhavya Desai.
Thank you so much, Bhavya.
I think it's going to be very difficult for me to call you Dr. Rajiv Kovil. The reason is because I always refer to you as Doctor. But I'm super excited about this conversation because I think you're obviously one of the top and the most reputed diabetologists.
Thank you so much, Bhavya.
And I think in terms of the conversation as well and what we talk about, I think उससे काफी benefit होगा बहुत सारे लोगों को, because diabetes को लेके मेरे हिसाब से most people have a lot of some myths, some misunderstandings as well, because काफी misinformation भी होती है out there. So excited to have this conversation with you. If you'd like to just say something, then that'd be great. Then after that, immediately we can start.
I think, Bhavya, it's nice that we have come on a platform like this, because diabetes is something which is across. A lot of people think that it's my neighbor is going to get diabetes, but we have almost close to 10 crore people with diabetes, and around 13 crore people who are borderline and who are very hungry to join that gang. So you have a huge gang of people with diabetes. And one needs to understand the problem, and that's where a lot of education about the problem needs to be done. And that education needs to be done from experts who know about the disorder. Because what is happening is that a lot of people come and talk about it, but actually not realizing that the patients who are listening to them, or people with diabetes who are listening to them, actually get confused after seeing it. So it's important that the right communication and the right kind of education goes to patients. And that's the only way they can treat diabetes.
Understand. Okay, that's very interesting. I mean, and I completely agree with you. So these are the things that I actually want to talk to you about, and I will obviously bracket them or portion them into the podcast at some point of time. But first, for the first few things, I actually had very basic set of questions because I wanted to clear out those myths, the kind of misinformation, the misunderstanding that people might have. So first one is as basic as it gets. Now, सबसे ज़्यादा misinterpretation of usually people have कि diabetes sugar से होता है, meaning मीठा खाने से होता है. So one is that the reason, or how does diabetes really happen? Can you just break that down for us?
Very nice. बहुत अच्छा क्वेश्चन है पहली बात, बिकॉज लोगों को लगता है कि हम मीठा खाएंगे तो डायबिटीज होगा, नहीं खाएंगे तो नहीं होगा. सो कंप्लीट मिसकॉन्सेप्शन. ओके, डायबिटीज इज अ हेरिडिटरी प्रॉब्लम. इंग्लिश में कहते हैं कि हेरिडिटी लोड्स द गन एंड यू पुल द ट्रिगर. Your lifestyle, your stress, the way you run around in life, way you are trying to catch a train at a particular time, reach an office at a particular time, targets every month, targets, work, pressures, children, extramarital affairs, so many issues in people's lives that this stress lands up in irregular eating habits, irregular exercise habits. And what actually happens is not about sugar. It's about deposition of fat. In diabetes, where the core problem is insulin resistance, the ectopic deposition is what we call it in medical language. But the deposition of fat, which actually should occur under your skin, gets deposited in wrong parts of your body, like your liver. Then you get a fatty liver. It gets deposited in your neck. It gets deposited in your abdomen. It gets deposited in your pancreas, and the functioning of each organ goes down. So there are a lot of pathophysiologies which tells us, but majority is this fat deposition, and then the pancreas tries to compensate. So more amount of calories, lesser expenditure of calories is a very simple way to put it. But heredity tells us how the fat is distributed in our body, because you have somebody who's fat on the waist, there's somebody who's fat on the lower part of the body, somebody's fat on the face, but majority of Indians are fat around their abdominal area. And that is what predisposes us to abdominal obesity, and obesity drives diabetes, heart disease, kidney disease, blood pressure, cholesterol, everything. So it is all a common soil. So you can't compartmentalize diabetes, you can't compartmentalize this. They are not different jars, they are all the same. So it all comes from the common soil, and if we can treat the common soil, then we can prevent all these problems.
I understand. So that means that the biggest driver is, of course, the hereditary genes or whatever, passing it on from the parents to the children and so on into that chain. But then once you have it, I think contact is a very wrong word. Once you have it, then when you consume a lot of sugar or such foods or food items, that's the one which basically.
So I'll explain it to you. Like a few centuries back, your forefathers and my forefathers, they never could get the amount of food that they wanted. So 200, 300, 400 years back, our genes were developed in such a way that whatever you eat gets stored in your body. That's called as the thrifty gene. And because you don't know, for the next 3 or 4 days you may just not get any food. So that is a theory where you keep on storing fat. And that is an adaptive process, because when you are not eating, when there is a famine, when there is starvation, your body starts giving you the calories. Now when this kind of a person for 200, 300 years gets exposed to a lot of energy dense food, then everything gets stored. So in the last 30, 40 years, we have been exposed to the Coca-Colonization of the world. So whatever we are eating gets stored, because our genes don't change in 100 years. It takes 200, 300, 500 years for the genes to change. So the same genetic material has come to us, which helps us to store food, so that next day you may not get. So this adaptive gene becomes a maladaptive gene, and you end up storing everything. And along with that comes, because of so many modernization, your activity goes down. You become more sedentary, you get more stressed in life. So everything adds on to this whole wrong gene. And this gene will now convert over maybe 200, 300 years. So we are storing whatever food we are getting, and we are not spending it. So the body, obviously the mechanism of the body is not good enough to take care of these extra stores. So you will get fatty liver, which we call as non-alcoholic fatty liver disease. It's a part of diabetes itself. You may get pre-diabetes, young children, girls may get polycystic ovarian disease. Some people may land up with infertility problem. Some people may land up with obesity problem. Some people may have high cholesterol and high triglyceride. Some people may have high blood pressure. But it all is the same.
Okay.
Everything is the same. It's a wrong gene and this deposition of fat which occurs naturally, and you don't spend enough. You have high energy dense food, and that's how the time bomb comes in.
Yeah, because I mean, if I understand it correctly, I mean, I will circle back to that, because I think it is, at the end of the day, it is your body's capacity to break it down enough so that you don't get somebody who's a diabetic and a non-diabetic. I think the core difference between them is that their body, someone who's non-diabetic, uski body is able to break down all of that by creating enough insulin so that you don't have that challenge versus someone who's diabetic.
Absolutely.
Right? Yeah.
Absolutely.
So I think that's a very interesting point, and uske baare mein bhi I would love to talk a little bit later. But before that, like you said, somebody is like pre-diabetic XYZ. So is there really, like you said, that the gene pool or whatever the type can be, it all stems from one molecule as such. Are there types of diabetes also that people aren't aware of? Because for me as well, मुझे भी ऐसा लगता है कि diabetes जब कोई बोलता है तो मेरे दिमाग में भी ऐसे ही आता है कि it's only diabetes. It is not like there is some different types of diabetes, but I understand there are there?
There are. So 30 years back when I started, we had only two clear distinctions. One class of diabetes comes in children and they require insulin, and in those days they were called IDDMs, insulin dependent diabetics, which around 25 years back they called type 1 diabetes. And there was another class which was called NIDDM, which is non-insulin dependent diabetes, which is more in middle age, and they were called type 2 diabetes. But now it's very heterogeneous. You know, that kind of homogeneous pattern is not there anymore. So you have type 1 diabetes, you have type 2 diabetes, which together forms the major chunk. You also have diabetes in the young. You know, you have young children with diabetes. So they either have a young type 2, they either have type 1, or there are other types of diabetes called autoimmune diabetes in adults. There are other types of diabetes called maturity onset diabetes in the young. That's why when you have diabetes at a very abnormal age, like very young age, it's very important to do certain kind of investigations to get to your diagnosis. Everybody is chasing that the sugar comes down. But it's very important to get your diagnosis of what type you have. You can have secondary forms of diabetes also, something related to the liver, something related to the pancreas, and they are called type 3C diabetes, and multiple other forms. So it's very important that if you get diabetes very young, you know, then you have to classify the type of diabetes, because till 30 years back, a young child with diabetes was always a type 1. That has changed. You know, you have adolescents with type 2 and many other types of diabetes. So it's very important that we class, and that there are now technology has gone up and the investigations have gone up, that we can actually have a kind of a kundali for the diabetes patient. You can actually look at what can happen for you in future. So a doctor can be an astrologer, and that's the future for diabetes. You know, you're going to have gene mapping and genetic testings where we will tell you that, okay, this is this, and these are the drugs which will work for you, and these are the complications which you may get in 15 to 20 years, so start taking care of this. You know, so that becomes very easy for people. So yeah, so such kind of genetic testings are there for some forms, but in the next decade or so, you will have these coming for all the types of diabetes.
I understand. So basically so that is, a lot of those predictions are based on, of course, the data science and all the inputs that you already have from the existing patients, and on basis of that predictions happen. Okay, that's really very interesting actually. Now you said something about young diabetics. You know, I think that's a very interesting conversation. I would love to dwell on that a little bit more. Now, India essentially has the highest and the largest population of young people below 35 as such across the globe. Yet, I think in the last 2 or 3 or 4 years, I think most of the people that I've also started meeting as young as 22, 23, 24 years, 25 years old, a lot of them are they're diabetic, you know, and it's really rampant, which is so surprising, because earlier, as you said, like 30, 40, 50 years was the time when people would probably develop it. Why is it so rampant in youngsters of today?
So a lot of reasons, Bhavya, for that. Number one reason, like your child, when you take him out or when he has a birthday party, where will you give it? You'll give it at a pizza place or where they serve fries, where they serve burgers or kachoris and stuff like that. So a child is exposed to energy dense food right from very early in his childhood, number one. Number two, parents also in the last 25-30 years have slowly converted from the typical Indian thali kind of meal where you have a balanced meal to energy dense meal, and replacement of main meals with snacks has happened over the years. So, and over the years, 30-40 years back, a person used to never think, what will I eat tomorrow? Today a person thinks that tomorrow I'll have Mexican, day after I have Italian, afternoon is Chinese. So that is in the brain. There's something called as hedonic pleasure, which one gets from eating food, which was not there few years back or few decades back. So eating has also become a pleasurable behavior. That's why all the apps are making a lot of business. So apart from all these things, that a child is under a lot of stress today as compared to when we were children. You know, we had parks to play, and we will play majority of the time. We will stick to our timings. Today, the child is hardly playing. He's either content watching or he's on his handheld device. So plus he's eating these wrong foods. Plus he has got a lot of targets from school and homework. Plus there's a lot of peer pressure for him that he has to come first, second won't help. So a child goes into junior KG at 2 years of age when he doesn't even understand. He's exposed to a cola at 2.5 years of age where he does not know what is sweet and what is salt. So all these factors, when you put them together, you get diabetes much prematurely. So premature onset of diabetes has been occurring in India for the last 2.5 decades, and it's a very alarming problem. It's a very alarming problem, and you and me cannot solve it. And it needs a very strong governance, a very strong provisions on good and wrong food. Good food or healthy so-called food today is more expensive than the junk food. So your vegetables and fruits, which are supposed very healthy food, they have to be at dirt price. They have to be very cheap, so that's affordable to everybody. And whatever is junk has to have a premium pricing. Whatever is high energy dense food has to have higher pricing. So then the amount of intake of these food goes down. So if you decide tomorrow that I need to have healthy food in the city of Mumbai, you won't be able to. And if you have to eat healthy food, you'll have to pay 3 times the price.
Right.
So the child, so for him, what is accessible, what is easier and affordable and available is energy dense, cheaper food, processed food. So he eats that right from childhood. So what a person was doing in the 90s, probably starting wrong food at 25-30, today he's doing at 4 years of age. So by the time he's 20-25, he's already loaded the gun with everything. So that's it. And obesity is very high. Childhood obesity is also very high in India. The obesity in India stands at something like 355 million people with obesity, which is as much as the whole population of the US.
Exactly.
So we are looking at the underfed in some parts of the country, and people with overfeeding and overfeeding related problems, whether it's diabetes, cancer, blood pressure, cholesterol, heart disease in other parts of the country. So we have a complete heterogeneity in that. People are dying of malnutrition, people are dying with excess of food and problems like that. So and this rural urban divide is also changing. 2023 there's a huge report from the ICMR which tells that the urban rural divide, which used to be a divide, but now there are so many tier 1, tier 2, tier 3 city that there's no urban rural divide. Today the gap is reducing, and the same thing which is occurring in metros is occurring in rural India, and that's what is changing everything. The whole demography is changing.
So that's very interesting actually. So what I'm understanding is that there are 2 or 3 things which are major. Number one is obviously hereditary. naturally, because what's getting passed on to you from the gene pool. Number two is that there's a lot amount of stress, which obviously contributes to that. And number three is, of course, very, very critical point, which most people, obviously, I'm sure they know, is that they diet. So I want to get back to the diet part as well. But before that, I had one question for you. Is it kind of, it's on the similar lines of what we were talking about the young people. So if it's going to be so rampant, and you're saying that if the children or if everybody in today's day and age are exposed to that level of food, or they're loading with the loaded gun at like 3 or 4 years of age, is it safe to say that there is a very, very high possibility that in the next decade or two, maybe like 15 or 20 odd years, maybe like 1 out of 3 or 1 out or 2 out of 5 people in India will probably be diabetic?
It is true that by 2040, majority of the deaths which are occurring in India would come from non-communicable disorders, which puts diabetes, cardiovascular disease, cancers. They will be the drivers for that mortality. So that there needs to be a serious concern there, and that can occur only if there's good health awareness and health education. Now, without that, expecting people to learn by themselves is not possible, because they learn from others, and when the others are doing everything wrong, then you don't think you're doing something wrong. So if somebody is having dosas for dinner, or chole bhature for dinner, or chaat for dinner, this is what a child has seen in his house. He feels it's normal food. So
how do you stay away from that? I mean, for example, now I know you mentioned that quick commerce websites, you obviously have like exposure to a lot of these different types of foods. But naturally, I mean, from what it used to be about 5 decades back, where there was only a limited menu or limited number of items that you could have, to where we are today, how do you limit yourself from that? Isn't it like
that's where health education comes in.
Okay.
That's where knowledge impartment and health literacy comes in, because everybody is literate from their whatever spheres of work they are in. But when it comes to health literacy, you're completely illiterate. So first you have to identify the foods. I'm not saying you can never have these food. We all have a palate which needs to be satisfied. So the portion control remains to be the main motto in life. Whether you like the food or you don't like the food, the portion has to be limited. To some form of protein has to be the first portion that you take. So protein first and carb second has to be always there. Plus refined food. So whatever we eat as snacks is always very refined food. So that will make your sugar go up, it will go down very fast, and you will feel hungry even faster.
I understand.
So you end up eating more and more and more and more. So that is a process which needs, and that's why I say that process can start only if there is, the first thing is that if it affects your wallet. So the process cannot start otherwise. So first you need to pay more for wrong food. So any sugar containing beverage should be double the price of a non-sugar containing beverage. If that happens, any refined food should be double the price of vegetables. So if vegetables and fruits become cheaper and millets become cheaper in our country, then automatically people will choose those foods. At least we hope. With India's economy growing, you don't know. But again, some amount of health literacy to our people is extremely important, because people don't realize that you're eating wrong food. And for that, you need to be very clear that when you take a plate, whether it's at home or a restaurant, carbs come in last. So it's very typical in your house or my house to say that Bhavya eats 3 roti. So Bhavya is hungry or Bhavya is not hungry. Bhavya has to have 3 roti. Whether Bhavya has had 5 dishes along with that doesn't matter. So Bhavya, if he has 1 roti less, Bhavya has eaten less. So this roti count is a big problem. So you end up eating, you put a chapati or a carb into your plate, and you're forced to eat it, because we cannot let food go waste. So these are certain cultural habits, which we need to change.
But do you think that those cultural habits are changing quite a bit as well? Of course, from parents to parents, as the generations are passing. I completely understand the sort of anecdote that you gave is great, because usually whenever there's food which is prepared at anybody's home today, there is as you said, 5 rotis for him, 5 rotis, 3 rotis for him, 2 rotis here, 2 rotis here. And if that does not get over, then they'll be like, oh, look, you wasted food, or would you, because you've not either had a lot of food. But now the generation has changed, where there is I would say, a little bit more awareness than what it was before. So then the thought process is not like always, okay, you know what, there has to be a certain percentage of food that has to be made, and then that needs to be consumed. Do you think that's changing, or that's not? It's just getting worse?
The younger generation which is looking at it is looking at food and other ingredients which are fuel for us from a more cosmetic angle rather than a medical standpoint. Now food is fuel for us.
Right.
You know, that's how our body runs. But the younger generation is looking at food to make sure that they look better. You know, that's a very dangerous turn which is taken. And to look better, people are going to the edge of the cliff. You know, and they can slip very often there. So food needs to be very well managed at home. So the traditional Indian meal was always good. You know, and that has completely changed. So the replacement of a traditional meal with any kind of snack is going to worsen it. You know, you have to quench thirst with water majority of the time.
Right.
You know, you can't keep, you know, you end up going to cafes, you have a bottle in your hand, you have a coffee constantly going on. You need to quench your thirst with water. In between, if you need something, fine. But otherwise, majority of the people don't do that.
Right.
You know, and the whole idea about putting a mind into what is being served, and if you're in a restaurant, putting nutrition in your mind when you're ordering is extremely important. So sometimes your chef in a restaurant will have to scratch his brain. What is this guy ordering? I want it like this. I don't want it like this. So that is very important. So right from childhood, now if you go to a school, the canteen doesn't serve them anything good.
Yeah, true.
You know, so it has to start there. You know, if a canteen doesn't serve the child right food, and if there are 60 children in school, that means there's 60 birthday parties happening.
Right.
You know, so if that does not occur, and also the teachers are eating the same canteen food, then the canteen needs to be a healthy canteen.
Right.
Now that's the right way of education from there. And I have been advocating for the last decade or so that we need to have nutrition as a subject in school. A child doesn't need to learn geopolitics. He doesn't need to know how the coniferous trees look like. He will learn that, but he needs to learn nutrition. So by the time he's in a higher secondary, he knows what is right food and what is wrong food. And then he, you know, whether he wants to do, but he knows what is it.
But what level of monumental effort will it take for this to happen? I mean, let's be honest. There have been constant conversations surrounding a lot of the subjects and topics and things like that in textbooks and what they're teaching at secondary and, junior KG, XYZ, whatever. And that change itself has taken such a long time for them to implement, where textbooks are now basically removing chapters, adding chapters and XYZ. Do you really think it's realistically possible to actually include that?
So for that, one has to accept what, now we know that tobacco is a very big addiction. But according to me, tobacco is not the biggest addiction. Glucose is the biggest addiction.
Right.
People, so you can call them as a lot of names. You call them as he has got a sweet tooth, he's a foodie guy, he loves food. It's not. He requires that carb. He requires that, and that is an addictive behavior. There we need to cut that down. We need to understand that so when we tell somebody that, oh, he loves eating a sweet after food, we need to cut it there. We need to probably give him maybe give him a fruit instead of a mithai then.
Okay.
And change that kind of behavior. So culturally we have to change, number one. We have to change policies. That's extremely important. With cultural change, policy change. So if you are here and I come to your house and I say I have diabetes, you will try to put in a peda for me and say nothing will happen. With one peda, nothing will happen. But you go to a developed country and I visit you after 20 years and I say I am a diabetic, you would say, oh, there was a peda on table, I would not like to serve it to you because that's not right for you. So that it is not that while in here you are not concerned about me, but the environment is such. Environment tells you chalta hai, kuch nahi hota hai.
Okay.
You know, and that environment is what I call as illiteracy in health. If that needs to change, policy, culture, everything needs to change. So if your child comes first, you'll come and tell me, give me a laddu. You know, why should I take the laddu? Why should I eat the laddu? You know, so that culturally, you know, so that needs to change. So till that time, that doesn't change. So if we price laddu 3 times, you know, it will change. Nowadays, laddus are priced cheaper. The more percentage you get that much of discount. So, you know, so that's the thing.
Okay. So we spoke a little bit about the diet as well, doctor. Now, 2 questions. One is, what are the basic symptoms wherein people can possibly realize that they have or they are borderline diabetic? And a little deeper dive into that is that what is the difference between someone who's diabetic and who's not diabetic in terms of general life as well? You know, like a daily routine sort of a life, how will it affect them? How will it be an issue for them?
So from that, Bhavya, a person with diabetes is called as Bhavya Desai with diabetes and not a diabetic. This is a nomenclature change because you don't want to label somebody as, you know, a diabetic. So a person with diabetes or people with diabetes, you know, one, there are no symptoms.
Okay.
You know, you only 25 to 30% will have symptoms, and that also at very high blood sugar levels. So it's mandatory that you start checking at least by the age of 30. If not, if you have a strong family history, much younger than that. But at least by the age of 30, an annual checkup on your sugar, lipid, kidney profile, liver profile, extremely important. Because by the time majority get diagnosed, especially in other parts of India, they've already developed some complications. So today we see the person may say that I'm newly diagnosed, I've been diagnosed this year, but he's already harboring some complication, which means that he has had diabetes for a few years and it never got diagnosed. So he may have been diagnosed this year, but when we know that he has complication, we know that it's been a few years that he's got diabetes. And today, the treatment is very different. Like a decade and a half back, we were very sugar centric.
Okay.
We would just chase the sugar. But today we have got drugs which are based on patient's risk profile. So suppose the patient is overweight, then the drug profile is different. Suppose the patient has a kidney disease, then the drug is different. Suppose the patient has heart disease, then the drug is different. Suppose the patient has heart failure, the drug is different. So it's not a patient has liver disease, the drug is different. So it's not that you know, one size fits all. So it is tailored based on the person's complication or the person's risk factor. And today when we treat diabetes, we do a risk factor review.
Okay.
We see how many risks are you having. So you're a diabetic, you have blood pressure, you have cholesterol, you're a smoker, you're eating out, you're obese, then he becomes a very high risk for me. And if he has a strong family history of any of the problem, then he becomes a very, very high family, very high. So he needs to be given a lot more preventive checks as compared to a garden variety of patient who doesn't have any other things. He's very mildly diabetic, doesn't carry any other risk factors and stuff. So there needs to be categorization, risk categorization of people with diabetes.
I understand.
And that is the best way to treat this. So you cannot just look at the sugar as the problem. The sugar is the problem because of which you get diagnosed, but the treatment is based on multiple other factors surrounding it.
Okay.
You know, and that's how it has evolved in the last one and a half.
All of these measures, all of these compartmentalization and customization, which usually obviously happens depending on the symptoms that each of these individuals have, all of those will ideally treat it and keep it confined to the best possible level that it can be adhered to, right?
Right.
There is genuinely no best case scenario or possibility where it can either be reversed or it can really be taken back.
So the word reversal is wrong, which is being used. The actual word is called remission.
Okay.
Remission means where the person doesn't require medications for at least a period of a year.
Okay.
Okay. Now that can medically happen. Okay, that can medically happen with there's a trial which says that if you're on a very low caloric diet and you lose 10 to 15% of weight, and if you're very early in diabetes, within 5 to 6 years of diabetes, this remission can happen. But this remission will continue only till you are able to keep your weight under check.
Okay.
So once you go back to your habits, and within 5 months you will see that it's come back again. So that is not reversal, it's a remission.
Okay.
When you say reversal or cure, it's like it's never going to come back. It's like reversal of aging. You can't reverse aging. You know, so it's the same. So that word itself is a marketing word.
Okay.
The medical word is remission.
Okay.
And which can, so if you are, the diet and lifestyle are the cornerstone of therapy. The drugs or whatever injectables are added on to that.
Right.
So if your diet and lifestyle is fantastic, or you improve it and you're able to lose weight and you want to exercise well, you may not require a drug. But that requires a lot of effort, a lot of energy, a lot of time. If somebody is ready to dedicate, it's very much possible.
So that's what. So
we're talking about type 2 diabetes here.
okay. Okay. So it's very interesting. You also earlier, I'm like just trying to link the conversation of what you had mentioned earlier about understanding your diet or understanding your food sources. Now, I think why most of the people have started getting a very health conscious, they obviously try and see what they want to eat and XYZ. Do they really actually see what's the genuine ingredients list as well, which is coming on most of the products? Because that's where the actual
very good question. Coming to food labeling. Food labeling has gone horribly wrong in India. So when they say no added sugar, there's already sugar which was pre-existing. When they say high fiber, it just means you're 3% or 5% higher than the other one which is available. So these are confusing food labeling. So there has to be a very strong provision for these kind of confusing food labeling. And food labeling has to be very simple. You know, as you have a green dot for veg and a red dot for non-vegetarian, so people need to identify healthy foods in a much more simpler way. You know, trying to do food labeling and an evolved person may be able to decipher, but otherwise it's very difficult to do that. So food labeling per se has to become very simpler. The provisions and the rules and laws have to be much stricter. So these kind of gimmickry doesn't happen, and the person is able to identify healthy foods, because a lot of food which are considered healthy are not healthy at all.
Understand. What, according to you, are the top 3 or 4 things that a consumer should avoid when it comes to ingredients, when it comes to these foods, which can?
It's always portion.
Okay.
When I say that you can't eat, I've never said that you can't eat an ice cream.
Okay.
It has to be a cheat day can come once in 10 days, once in 15, based on what your profile is. You know, you can't eat wrong if you have some other kind of disorder happening.
No, true. I understand that.
But when you say overall, on a daily basis, you cannot have a lot of refined food. You cannot have a high density food, which is very high in sugar. You cannot have very high saturated fat food. You cannot have caloric beverages. You know, and these are things which you can avoid on a daily basis. Then if you have an occasion to celebrate, then obviously on that particular day you may sin in terms of your diet. But you have to compensate the next day by either exercising more or being better as such.
Understand.
But the principle is that even when you are sinning in terms of a diet, your portion has to be smaller, and your protein needs to come in first before your carb comes in. Or if you are a vegetarian and you can't have protein, you could preload with maybe a dry fruit, maybe with a salad, maybe with a soup, so that the carb and the overall dense food, the portion is smaller.
So, but in these cases, like, are a lot of these newer kind of, you know, these, I mean, it's more of like a sort of a dietary sort of question, you know, but I think that you'll be able to address it really well. A lot of these intermittent fasting, which has become such a big trend, and people actually say, I've had friends who've done intermittent fasting for a bit, and they actually say that it is something which was done for many years and decades ago. It is a very healthy habit, wherein you have to do this, even for example these keto diets and XYZ, are these genuinely healthy habits?
So there's a lot of data there. This time restricted eating is one of intermittent fasting, and whether you eat in a shorter period of time or whether you eat the same amount of calories distributed, the benefits are the same. Plus, when you go on a keto, you are risking a lot of issues. So if you are going on a keto, it's for a very short period of time. It has to be under expert guidance after doing a lot of checks. It has to be for a very short period of time, probably just to look good on a photograph. Not more than that, because it's not a long-term exercise. Same is for IF. And if there is a lot of yo-yo in diet, you'll end up with a lot of gastrointestinal gallstone disease, the obesity will come in. So yo-yo in diet is even worse. So these kind of things cannot be taken for a long period of time. That's number one. And two is that very early, if you're a pre-diabetic or high risk for diabetes, and you need to just jumpstart your metabolism, or you want to look at the weighing scale smiling back at you, and if that is what you want, then you can start off this, but you can't continue it for long.
I understand. Right. Now, you spoke about saturated fats and XYZ. A lot of that also is in terms of what we are doing in terms of food. It also stems from oil as well that we eat. Most of the things which are really marketed today, that is like ex-refined oil, 7 times filtered, this, that, and all of that, is it any different than what you'd say? For example, I have this challenge at my place constantly all the time, where because of the thought process, my parents still feel that groundnut oil, guinea oil, what they say, which is there at everybody's house, that's really good. And that's great. And in comparison, I think the younger generation, they'll be like, well, you have your Safolas and you have XYZ, which are more refined. So is there any truth to any of those factors?
So oil is a dilemma which nobody can ever solve. Because when you look at groundnut oil, for example, or a blenderized oil, for example, you are looking at omega-3, omega-6 ratios there, which for groundnut is good. But it is always again the portion. So if you exceed the portion, then obviously it's going to do more harm for you. So even saturated fat, which is your ghee and butter, now that if you have excess, it can give you a problem. So our routine guidance at home to people is that a person requires around 500 to 700 to a max of 800 ml of oil per person per month. So buy oil, whatever, whether it's oil, whether it's butter, whether it's ghee, on the first of the month, and multiply it this way, and then try to make it last the whole month, so that you at least know the source, you at least know how much has come in terms of quantity. Many people buy 15 liters, 20 liters of oil, so they have no idea how much is being consumed. Plus every day it's an app-based somebody delivering also. So that needs to be cut there where it is coming in. So trying to get into this debate, it's a never-ending debate. Because each one has its own benefit, has its own shortfalls. Some are good for garnishing, some are good for frying, some gets worse when they fry. So if you're able to cut the portion of it, it's the best way to treat it.
I wanted to also ask, I know that this portion or this question is more like of what an individual's personal choice is. But I recently actually just had written a book, which is my 3rd book on alcohol. And in that, a major portion and a major chapter was actually on how the younger generation is also looking at sustainability and also are a little bit more aware of what they want to eat as compared to what the earlier decades were. In that, they're also doing a lot better in terms of drinking as well. They are more conscious about the benefits of drinking, or what I would say the non-benefits or the bad habits when it comes to drinking as well. For someone who's actually either diagnosed with diabetes, then if you are someone who's smoking and drinking as well, I know it's a personal choice, but how is that? Does that really worsen or have a much bigger impact on your health than vis-a-vis someone who's just purely diabetic?
So yes, smoking by itself causes the same cardiovascular damage which diabetes does. A person with diabetes who smokes, it's not 1 plus 1 is equal to 2, it's 1 plus 1 is equal to 5.
Okay.
Okay, so smoking, I mean tobacco in any form, whether it's chewing or smoking, is out. In terms of alcohol, when it comes to alcohol, you need to first assess the patient, evaluate the patient, number one. You know, liver disease, very, very common. Almost 75% of people with diabetes have some form of non-alcoholic fatty liver disease. 35% of the population has it. 50-60% of young children have some form of fatty liver disease. So first, whether there is any kind of affection, any kind of affection on the nerves. Okay. Neuropathy is very high in people with diabetes because you don't want to have an insensitive or anesthetic foot. Okay. Once you have assessed all that, then the advice is to have social drinking only. And again, the portion comes in there.
Okay.
You know, and have drinks without any mixers, caloric mixers.
Okay.
That's it. Because otherwise, you will end up having alcohol, which gives you some empty calories, and some sugar beverages, which is giving you a very, very high calorie. Again, eat after a meal. Another misconception among people who take alcohol occasionally also is that they need to skip the medicine after while they drink.
Okay.
You know, so you don't have to skip medicines when you drink also. So a lot of people skip their medications when they drink. So these are all but before one can advise on what kind of social drinking, you need to evaluate that.
Understand.
You know, and that's extremely important. But tobacco is a complete no as a blanket rule for people with diabetes.
Right. Now, I want to actually change the conversation a little bit about mental health as well. You know, number one, what sort of an impact does diabetes have on an individual when it comes to mental health as well? The reason is because as it progresses further and further, I think it will reduce their capability and the capacity to do things. So first I wanted to just ask about, like, from a younger people's perspective, and then probably we can go to more of like the aging side.
So very good question, Bhavya, because this is a part of diabetes which is never spoken about, and people don't understand that also. But there's something called diabetes distress.
Okay.
You know, where a person of diabetes is distressed and he feels impending doom the next day. He would never confess it to his spouse also. But he feels depressed, he feels distressed because of the regimen or the regimen that he has to follow for the rest of his life. So it's extremely important that you do things which are practical for you.
Okay.
You don't do things which are, you don't do a complete no to everything, and you know, then there's a rebound happening. So there has to be a practical solution to this. Second, there needs to be, the person may be depressed, probably one because of diabetes, but majority people who get depressed or have mental health are people who have complications.
Okay.
So once they develop maybe a sight-threatening vision problem,
right,
or a liver problem or a foot problem, then that depression multiplies. So it's very important that they are able to, or even a sexual problem from that matter. That's where the depression or the mental health goes up and the frustration goes up.
Right.
So it's extremely important that people with diabetes discuss with their healthcare doctor, and also vice versa, that the doctor tries to put a regimen which is very simpler for the patient.
Okay.
You know, simple things are easier to adhere rather than difficult things. So telling him to take a drug one half an hour before, one during, one after, one at bedtime, one this, eat this way, and for a person who's already facing the brunt of everything, will not be able to comply. So you need to have some kind of empathy to that person. And you have to think about what he goes through, and that's bi-directional.
Right.
The person should also come out that, you know, this is getting too complex for me, you know, and the healthcare doctor should also look at giving it, because simple things are always easier. If you do simple things right, That's what diabetes tells us to do.
Okay.
Eat right, exercise right. But if you tell them in the most simplest of languages, the communication is better. And if the narrative is simple, the person will be encouraged to do it. Instead of telling him don't do this.
Right.
The communication is the key for him to go back better in this mental frame of mind.
Yeah, but I think many times it's also a little difficult for a lot of the people around to kind of understand that as well. Because I think a very important point that you mentioned is about, how in terms of mental health, what these patients go through. Like, for example, I, out of my own experiences, have seen people who've been supremely confident throughout their life, and they've been doing excellent, and they're amazing in terms of what needs to be done. And then as their diabetes has progressed, I've seen versions of them which are so different from the level in terms of confidence, from the level in terms of mental health. Everything kind of it slowly kind of starts falling apart, and it's a real thing. And the thing is that I feel that possibly, for someone like me who's not in that position, because I'm not diabetic yet, or I hope I'm not at some point, it's difficult to understand, what they're going through, what their state is. It's extremely challenging.
So the discrimination can occur at home also. That Bhavya, he's a diabetic, don't give him this. But yes, give that. So, a diabetic friendly food, if I can call that, is a friendly food for everybody in the family. It's a healthy diet.
Okay.
So that needs to be encouraged around. And what you're saying is true, is that a person's personality changes when his mental health changes. And that's extremely, it's a very touchy, empathetic topic that somehow many of the doctors also miss it, because there's so many things to consider in a person with diabetes. But that's somewhere that will make a difference between a person adhering to the principles of treatment. That empathetic solution has to be given to the person.
I understand. So very interesting thing that you actually spoke about, of course, in terms of mental health as well. I think definitely I've seen people who really don't discuss problems like these, whether it's with family, whether it's with doctors, whether it's with friends as well as such. Another follow-up question I had was that even when they discuss it with doctors as well, say for example, if they're having some of these challenges, do you think all doctors are in that sort of a mind frame or sort of a position where they really are able to talk and discuss about a lot of these things? Because let's face it, doctors are also extremely busy, and of course, the more popular ones like you, they have a long line of patients who are always waiting outside. And how much of time can you really give everyone?
So, Bhavya, a person with diabetes requires a multidisciplinary approach.
Okay.
Unfortunately, because it's out of pocket, a person cannot afford multiple disciplines of doctors. So we emphasize that a person needs to go to a. We have that kind of luxury of having educators and nutritionists with us. But a psychologist is someone who should be an integral part of the team.
Okay.
But that comes with a fee. It cannot come. So that's a problem. So sometimes in many places the doctor needs to be the dietitian, needs to be the educator, needs to be the psychologist, need to be many other roles. So he has multiple hats to put in there. But mental health is something which a person with diabetes and the doctor need to talk about, because unless we both are on the same side, we are talking the same language, and he's able to adhere to what I'm saying, otherwise the outcomes will change.
Okay.
So it's very, very important for the doctor to understand the person. So there has to be a very open conversation. There's no point in nodding to everything that the doctor says. So this is not possible for me.
Got it.
My lifestyle is such. Try to make it modified based on what I have. So that is a true heart-to-heart conversation is extremely important.
I understand. Right.
And mental health problems are very high, very, very high. Unfortunately, they are not spoken about. And if spoken about, a drug is given instead of a lot more counseling, and that is because about the load and the time per person that we can have.
Right. Now, another social stigma, or at least what you call a personal stigma that a lot of people don't discuss about, which you touched upon, is the sexual impact or challenges that a person can have. And I think even apart from mental health, I think that's a bigger stigma that I guess 99% or 90% of the patients probably won't discuss. How do you, I mean, what exactly happens in situations like this? How is it different in terms of in this?
So it's very important that you brought out this question, because it's very prevalent. But unfortunately, it is spoken by the person with diabetes only when he has a major problem.
Okay.
So sexual functions in men as well as sexual function in women are very prevalent. So in men it starts right from loss of libido,
okay,
to premature ejaculation, to erectile dysfunction, and sometimes fungal infections. In women also, right from poor lubrication to fungal infections to painful intercourse. So they go through a lot of these problems in their personal lives, and it needs to be discussed. The person discusses only when he gets a severe erectile dysfunction. So we have educators, dietitians, there are certain questionnaires which person can fill, and then we naturally lead them to that question, because you directly cannot ask somebody that question, because some people do not, you're invading my personal space. But we can, through a particular pathway, you can reach that person's question that he wants. Most people, when they do that also in cabins, they want to make sure the spouse goes out, and I always tell them, call the spouse in. Because that's what you want to discuss.
Right.
But
it
has to be an open conversation. So many a time the person will tell the spouse to, step out of the cabin, and I'd like to discuss this with you. No, call her or him in, because it's a problem which is affecting the two of you all.
Right.
And and majority of the time it could be psychological as well. So in younger people, it's always psychological, rather than a pathological cause being there. So people have this some kind of fantasy about things, and they're not able to. So that is a psychological issue in majority of the younger people with diabetes. As you grow older, diabetes by itself can reduce the male hormone, which we call as late onset hypogonadism, which can cause some amount of loss of libido and problems like that. So there are problems, there are solutions to the problem. Most importantly, there are solutions to every problem.
Right.
But that can be spoken only when the person is able to have a conversation.
Understand, right. But realistically, I mean, maybe I know in general we spoke a little bit about this, that it is not possible to prevent or do things, but realistically, do you think maybe like a decade or two down, especially with some of the things that you're talking about in terms of technology, at any point of time, do you think there's a possibility of a cure coming in for diabetes?
So good question, because the problem with diabetes is the excess deposition of fat, which we started off with. If we can remove the deposition of fat in whatever way, diabetes will come down, sugar will come down, cholesterol will come down. So there are a lot of therapies which are directed towards obesity now, and they're a rage globally. And the newer drugs in the pipeline also look at weight, also look at removal of fat from the liver. So these drugs, so right now they are in phase 2 studies. They will come into the market in another 5 to 6 years, or maybe earlier than that also. But the group of drugs looks very promising. Where they are able, but the pharmacotherapy or drug therapy for obesity is going to be lifelong, like diabetes.
Right.
And they may be able to get your weight down by 20-25%. And keep you down. And if that you can do earlier on in diabetes, then obviously it's not a cure, it's the remission we spoke about.
Understand.
Right. And so to stay off diabetes, blood pressure, cholesterol, heart failure, cancer, if you can treat the mother of the problem, which is obesity, then it makes a lot of sense.
Understand.
You know, even from a government framework, it makes a lot of sense that you treat the core problem, and then all the byproducts of the problem do not come in at all.
Right, right. What is the correlation between obesity and diabetes? I mean, I know that we spoke a little bit about, you know, how diabetes is rampant amongst a lot of the younger people or the younger generation that we are seeing, but is there a very high correlation between these two, or the problems stem from each other?
So there are sort of multiple schools of thought about how diabetes came in. You know, you will have different versions, and earlier when I was a student, it was only insulin and insulin not working, and now we have 8 pathways to it, and it's emerging, and that's how diabetes, which was a very cold subject, and obesity, which is a very cold subject, is today evolved into a very revolutionizing chapter by itself.
Right.
So obesity by itself, if I can say, the brain is the kingpin here. Okay, the brain decides where fat is distributed.
Right.
The liver is the foot soldier. Okay, the liver is like the local mafia who decides, you know, and where the fat is, whether it serves it there or it's put around. The muscles are the various sleeper cells, if we can call it.
Right.
The muscles and the other tissues are sleeper cells where fats can come in.
Right.
And then these excess fats, then they actually crosstalk with each other. So data suggests that if you have 7 grams of fat in your pancreas, it can give you diabetes. And when we say weight loss, then your amount of fat in your pancreas goes down below 3 grams. So there's no drug today to just remove fat selectively from organs.
Okay.
So when you overall lose fat, and you know, the liver loses fat, the pancreas loses fat, and your diabetes comes down.
Okay.
So as such, the deposition of fat, okay, with the brain deciding it, afterwards the excess consumption and sedentary lifestyle makes it again deposit in organs where it should not be deposited, and then these organs actually crosstalk, and then it's like they bomb together, and you may get a person with NAFLD not progressing towards diabetes,
okay,
but progressing towards cirrhosis of liver. You may get a person with obesity going into heart failure and not progressing towards diabetes.
Okay.
So as far as your pancreas can compensate for the load that you are having, you may not develop diabetes. You may be a pre-diabetes or you may be normal, but the insulin resistance inside can go give you all these other problems.
Okay.
All these other problems. So it stems from the same core defect, which is insulin resistance.
I understand. But even if someone is diabetic, they can still maintain an extremely healthy lifestyle.
Absolutely.
In terms of social lifestyle.
Absolutely.
Sports, playing, going out, XYZ.
Absolutely. Absolutely. So there need not be any kind of cobwebs in people's minds that if you're a diabetic you need to restrict X, Y, Z. I cannot go out and meet people, I cannot attend this, I cannot go to a party. No, it's not like that. You need to obviously get some amount of moderation in many things you may have done to get diabetes. Obviously that needs to be there, but other than that there's not so much of restrictions, you know. So there are people who jump time zone, there are people who go around, but they know how to treat themselves, and today technology has come in a very, very big way, you know. So most of the people use the technology which is called continuous glucose monitoring system, CGMS, where you can track your blood sugar and your sugar every 5 to 10 minutes, and you get a live streaming of your sugar. So you know what is happening exactly. So people are able to identify right food, wrong food. People are able to identify patterns. You know, this kind of a pattern makes my sugar spike, or this kind of things makes my sugar spike. Stress, lack of sleep, which nobody ever talks about. Sleep disturbances, obesity, sleep apneas, all these are a part of the whole diabetes process, you know. So sleep disturbances can make my sugar shoot up. You know, stress can make my sugar shoot up. So all these are things which AI has come in a much, much better way and helping us. So technology So we have become now diabetotechnologists because it has evolved in a very big way in chronic care.
Right. So very interesting. This last one question is that now you have a lot of these gadgets, a lot of this technology which comes in wherein people, like for example, you said sleep apnea and things like that. When you wear your smartwatches today, you can actually check the different, I forgot the technical term for it, but the different hours of sleep and the different types of sleep or the modes that you actually go in. How much of that is really applicable and authentic wherein you can, some meaningful data comes out of that?
So there are a few FDA approved devices for that, which can actually track your sleep properly and will actually tell you, because there is an REM sleep, NREM sleep, the cycle keeps coming, you know. So it all depends on you know, you want to use a FDA approved machine to track it. A lot of gimmickry also occurs there, you know, a lot of wearable devices, we don't know whether they are approved. Some of them are approved. Some of them are approved. Some of the smartwatches are able to track these things based on not those electrodes, but they're based on your pulse rate. You know, and they have a very meaningful outcome based theories there, data there. So, but not all these wearable devices are approved devices as such. But what it helps is that at least it brings that concept into that person. That, you know, sleep is a very important part of the treatment.
Right.
You know, and that itself is a huge beginning. You know, because sleep disordered breathing is very high in people with diabetes and obesity. It's almost close to 40 to 50%. And sleep apnea is 15 to 20%. So it's very high, and that could be the reason for your obesity or vice versa. That could be the reason for your blood pressure or vice versa. And this doesn't get picked.
Yeah, because I also myself didn't know actually that there are these different states of sleep like your REMs and XYZ until actually I started reviewing a lot of these gadgets and when they started marketing and promoting it honestly. But say for example, just to simply break it down, like will Apple Watch really tell you whether you are in the different states of sleeps that you are? Is that actionable?
It is actionable. I don't want to name the brand per se because the watch does get your rhythm of one lead. Okay, and in developed countries that rhythm is linked to the online service, online health service. So if your rhythm changes, okay, there's a sudden, like you have an emergency contact number on your phone. The trigger is given to the closest hospital station, and they know that this guy there has a rhythm problem, and the closest defibrillator for him is there. So yes, this is the future. Wearable FDA approved devices will be the future but again, it doesn't mean that is going to solve our problems. You know, because India's problems are big. Our population is big. We can't have every person with wearable devices walking around. You know, that is not going to happen. So I think the technology is surely going to help us understand people better. But finally, the people, the government and policies need to change.
Understand.
Then only the outcomes will change as such.
Okay. What is the 3 biggest leapfrogs, or like in terms of generally in the field, that have really happened according to you in the past decade or so? You know, which has been the biggest progresses that we've made when it comes to diabetes?
So one is that we were very sugar centric. Now we treat people according to risk factor profiling. 2, drugs have come in which initially came in as drugs for diabetes, but now they are gone in to treat heart failure, prevent heart disease, prevent kidney disease, and treat kidney disease also in people without diabetes. There are drugs which came in for diabetes treatment, but now they have progressed towards treatment of obesity and treatment of non-alcoholic fatty liver disease. So our whole approach towards people with diabetes has changed from 2008 onwards. So it's been 1.5 decades where things have completely revolutionized here. And it's not that a person comes with a sugar of 300 and he gets the same treatment. You know, a lot of variability will be there, and variability will be there based on very good guidelines coming from bigger associations, which are based on robust evidences.
Okay.
So it's not like it's some guys whims and fancies. It's proper evidence-based medicine is happening, at least in this field. So your weight is taken into criteria, your heart problems, your kidney problems, whether you have a risk for low sugars, all those things are put in, and that is how your drug comes in. Your drug doesn't come in just because if your sugar is high, I'll give you 3 drugs. Your sugar is low, I'll cut down it into 2 drugs. That does not happen that way.
I understand. Okay, one final one, that it's a very common notion that people have, especially when it comes to the sort of a medical system that we have in India, you know, wherein a lot of times they don't actually go to see doctors because they feel that a lot of the field is commercially driven, you know. It also stops a lot of people to actually come and test themselves for your HbA1cs and then going to someone who's a really good doctor as well. You know, do you see a lot of that? And is it like really rampant in that respect? That, I mean, from a medical field standpoint, I know at the end of the day you have to look at your own interests as well. You know, the community.
So let me put it this way, you know, that because India is out of pocket, you know, every money you spend, you need to have value for it.
Right.
You know, you need to have return on that value, and that's how you think. But you have to realize that this particular is whatever you spend on health is a sort of an investment on yourself. Lot of people put it into an expenditure. That when they do tests and the tests come normal, they say, so, kuch nahi tha. Kuch nahi tha. So if the test comes, there's something on the test, then that is abnormal. So that preventive approach does not come in because it's out of pocket. Now, I am very optimistic that good insurance will come in for people with diabetes, and at least a decade later, we will have much more preventive health checkups which are driven by insurance, making sure that people live longer without complications. So expenditure on your health should be considered as an investment. And if that mindset can change, you know, things can change drastically, because people spend almost 20 times the same amount in a month on wrong things, wrong food, wrong choices. You know, and investment in terms of whether it's medications, whether it's doctor's consultation or tests, will be much better and preventive and cheaper in the longer run. You know.
Great, understand. Thank you so much, doctor, for having this conversation. I mean, it was so interesting. I mean, I think there's still so many questions that I have which I really want to ask about, but I think I'll definitely leave that, because we have to chat again, because I feel that, you know, you're not just a powerhouse in terms of knowledge when it comes to only the subject of diabetes. Because diabetes is linked to so many other things, which is your diet, which is your health, which is food, which is everything in terms of the social stigmas attached to it. I think that conversation can be, I think it can have like so many different avenues that we can actually explore.
Thank you so much, Bhavya. I don't know powerhouse or no. I think a lot of us still have a lot of empathy for our people with diabetes, and a lot, and that comes from within. That, you know, as your last remark was whether there's commercialization. There is commercialization purely because the industrialists have come into healthcare. You know, if it was driven by doctors and driven by government, there won't be any commercialization.
Right.
But we just hope that this conversation was very good. We should have a second round also. Yes. And thank you so much for calling me here. And I hope it benefits a lot of people who view us here. Thank you so much.
Thank you so much.
Thank you, dear.
Yeah.
Pleasure being here.